Have any of y'all taken the Bale Deneen course for cardiovascular prevention? If you don't know Brad Bale and Amy Deneen's continuing medical education class, it really is worth attending. It was my first introduction to an interdisciplinary CME event in which dentists and doctors sat side by side in the room, because no cardiovascular prevention program is complete without a dentist on the team. And now I would actually expand that to say no cardiovascular prevention program is complete without a good biological dentist on the team. Because after having learned my stuff from Amy and Brad and trying to implement it with my general dentists, I kept hitting brick walls. And I would say, I need you to look at the tooth root. Don't just do that bite wing. I need you to look at the tooth root of that tooth. And I would get resistance. And they would say, I don't do that. Or I would send them with a periopath that showed oral bacteria dysbiosis, and I would say, can you fix that? And they'd say, oh, that's the job of the periodontist. So working with a good biological dentist, and I'm blessed in Atlanta to have many to choose from. But today we're going to talk about how the mouth and the heart are directly connected. So my slides are, well, I guess I thought you guys had a copy of them, but if you don't, I'm happy to share them. You can get them however you want, electronically or paper. We'll make sure you get them. But we have 4 major objectives. We're going to talk about the role of the mouth in nitric oxide generation. We're going to talk about 3 mechanisms that oral gram-negative bacteria play in advancing atherosclerosis. We're going to talk about the role of vitamin K2 in cardiovascular prevention. And then we're going to teach you, I think many of you already know, but in case you don't, we're going to talk about a dental meridian chart that can help you to localize your oral pathology, unless you're blessed enough to have a biogenetic practitioner who can do that for you. So a man is as old as his arteries. And we have to begin our story with the story of the Nobel Prize for nitric oxide. And why is this not looking right? There's no pictures on here. Their faces are all missing. I don't know why it's not looking right. But so 3 docs identified Nobel Prize. The first guy recognized that acetylcholine, when present, actually dilated the endothelium. The second guy said, well, we've got some endothelial-derived relaxation factor, but it's a gas. And it turned out that that gas was nitric oxide. And then the third guy said nitroglycerin works by releasing nitric oxide that causes a relaxation of smooth muscle cells. So it is this discovery of nitric oxide and its function is one of the most important in the history of cardiovascular medicine. So I can't stand here and talk about cardiovascular prevention if I don't talk about nitric oxide. Well, what is it? It's a chemical compound that's a gas. It's got the chemical formula NO, so I'm not yelling no at you when I put NO up there. It is one of the most important signaling molecules in the body of mammals, including humans, and it's one of the very few gaseous signaling molecules that we're aware of. It also can be a toxic air pollutant produced by automobile engines and power plants. And you don't want to confuse it with nitrous oxide, the anesthetic you're familiar with. And little side note, Pearl here. If your patient has MTHFR gene mutation, please don't use nitric oxide as an anesthetic for them if you don't already know that. It increases their risk of postoperative stroke slightly. So you don't want to use laughing gas in your MTHFR patients. At least in the MTHFR C677T homozygous patient. That's what the studies were done in. The nitric oxide molecule is a free radical, which is relevant to understanding its high reactivity. It does react with oxygen in the air to form nitrogen dioxide. So why is this molecule so important, not just to cardiovascular? Because as you can see here, it's a key regulatory role in the regulation of many vital biological functions. In the urogenital tract, we think about nitric oxide in the role of penile erection. We heard earlier from Dr. Hickey about how preterm labor and preeclampsia can be related in part to nitric oxide, and how heavy metals scavenge that nitric oxide and make it less available. We talk about the role of nitric oxide in the respiratory tract for bronchodilation. We hear about the role of nitric oxide in cellular proliferation, in angiogenesis, in triggering cellular apoptosis, right? If you don't trigger apoptosis, you have unregulated cell growth, and that leads to cancer. in the central nervous system, learning, memory, pain sensitization. Here's another place in those fibromyalgia patients where they're all jacked up and their pain mechanisms are all on high alert because they don't have enough nitric oxide, even contributing to epilepsy, neurodegeneration, and of course blood pressure control. And I'll spend a bit of time on that. Regeneration of stem cells, targeted differentiation of cells in the peripheral nervous system, in the cardiovascular system, of course. Vasoregulation, blood cell regulation, myocardial contractility, and microvascular permeability. So we think about nitric oxide often only two places, the arteries and the penis, but in reality, it's all these other places as well. So there's a beautiful graph here that you can see, sort of, that shows that as you age, nitric oxide levels drop, and there's an age-related decline. There's also a picture that's not showing up. I don't know why my graphics are showing. Does anybody know Macs well enough? This is a new Mac to me, and it's not doing what it's supposed to do. But so nitric oxide does drop as you age. So the younger people have less of a problem. The older people have more of a problem. This is a picture of an artery with atherosclerotic plaque. As we know, atherosclerosis begins to build behind the drywall, behind the endothelium, before it builds big enough to cause plaque rupture into the lumen of the cell. And as you age, we have more and more and more loss of nitric oxide and thicker and thicker and thicker plaque. So how do we make nitric oxide? Well, you start on the left with arginine. You go through three nitric oxide synthase pathways, the neuronal, the inducible, and the endothelial. And on the other side, you end up with citrulline and nitric oxide. So the triggers for making nitric oxide are two primary things. Number one, you have to have an increase in intracellular calcium levels, and you have to have something like shear stress. So those two things will often trigger the NOS and the ENOS, but not the INOS. That nitric oxide synthase enzyme pathway is not dependent on the level of calcium. It is more dependent on the level of the binding of calmodulin. It doesn't respond so much to the calcium levels in the cells, and it does outlast the other isoforms of nitric oxide synthase. So the consequences of having nitric oxide insufficiency include hypertension, atherosclerosis, blood clots, Alzheimer's, erectile dysfunction, peripheral artery disease, immune dysfunction, cancer, and chronic inflammation. You can have problems with too much nitric oxide. It's sort of hard to get it, but if you do get too much nitric oxide, because it's so reactive, you can have neuropathic pain, inflammation, reperfusion injury, and neurodegenerative disorder. Nitric oxide is so important to the mammal, especially the human, that we have developed a backup plan. It's independent of that nitric oxide synthase pathway I showed you, and it's the alternative pathway, and it's called the nitrite, nitric oxide pathway. And it elevates nitric oxide through a sequential reduction of dietary nitrate provided by plant-based foods. So we have to eat the foods that allow us to reduce this nitrate. So this was a really cute graphic of Scooby-Doo, because Scooby-Doo says rut-row, and so this says rut-row, I've got nitrate, nitric oxide, and that's our backup plan. So half of the nitric oxide comes from our mouth. In our experimental animals, it's been estimated that about 50% of the nitric oxide comes from the mouth bacteria and the crypts of the tongue, provided that they're fed sufficient dietary nitrate. So this is one place where, once again, the primary care doctor, the cardiologist, has to be directly connected to the dentist, because when that oral flora is off, we're not going to make nitric oxide. We as primary care clinicians are going to have a really bugaboo time trying to get their blood pressure under control when they're nitric oxide deficient. And if you don't take good care of their mouths, we can't do our job. And you can't do your job if we don't take good care of the rest of them. So this is a picture of a person who is consuming nitrate foods. The foods then go from nitrate, they're reduced to nitrite in the saliva. In the stomach, converted to nitric oxide, and then excreted through the kidneys and the urine back out into nitrate. And why that's important is because you can measure in the saliva whether or not there's nitric oxide present. So that gives us we just have a little stick downstairs at the neogenesis booth. You can meet those guys and get a little nitric oxide stick and see if you are making adequate nitric oxide. Circulating nitrate is derived from dietary sources or endogenous nitric oxide production. It's then extracted from the blood by the salivary glands, where it's concentrated up to 10-fold more in the saliva than in the serum. And it's then reduced to nitrate back again by the oral microflora. So we're providing this constant amount of fuel for our saliva glands to produce nitric oxide. So which oral flora make nitric oxide in the mouth? Well, there are several of them, 4 primarily that have been identified: this Veillonella, Provotella, Neisseria, and Haemophilus. And that's important. I think we're going to find perhaps that we have some oral probiotic strategies coming down the path that can help enhance the growth of these as we reduce the growth of the ugly bacteria. And there's a picture of the top 10 ones if you want to see them. So the tongue and nitric oxide synthase is a very delicate balance for the heart and the brain. There's a potential link between bacterial nitrate, nitrite, and nitric oxide reducers and migraine headaches. Higher abundances in the oral cavity of people with migraines than in the oral cavity of people who do not. Might be a role for us going forward to help control our symptoms besides blood pressure using knowledge of this pathway. So what are some ways that we shouldn't do to decrease our nitric oxide? Well, if we have an insufficient dietary intake of nitrate and nitrite foods, among them one of the richest is beets, but also leafy green vegetables. We listen to Michael Pollan, eat food, mostly plants, not too much, right? We do need to be eating a diet that's mostly of plants. If there's problems with nitrate uptake in the duodenum, you won't convert it very well. If you have insufficient saliva production, you won't concentrate that nitric oxide very well. And if there's a lack of commensal bacteria to reduce the nitrate to the nitrite in the oral flora. And some things that alter this besides oral hygiene and antibiotics are antiseptic mouthwash. And my next slide, I'll talk about that. Also, insufficient stomach production, achlorhydria. As primary care doctors, we now know that probably the vast majority of our, quote, reflux patients do not have too much stomach acid. They probably have too little stomach acid, and this will lead to the reduction of their nitric oxide availability. And anything that increases oxidative stress that scavenges nitric oxide, not limited to, but also including heavy metals. So chlorhexidine mouthwash. How many of our dentists have ever recommended chlorhexidine mouthwash? Probably all of you at some time or another have used this. And we know that it can reduce the oral nitrate production by 90%. And what that means clinically to us is that can raise their systolic and diastolic blood pressure by 2 to 3.5 millimeters of mercury, and in some people substantially longer. So if you need chlorhexidine as part of an oral care program, please recognize to caution the patient, this is a very short-term strategy. We need to keep a good eye on your blood pressure. This is a risk and benefit ratio. We have to realize what we're doing here and recognize that our interventions can affect other things downstream besides just their mouth. So we have to do this delicately. Switching our attention away from nitric oxide to the role of the commensal oral bacteria. So cardiovascular plaque has bacteria in it. In this study, we showed 44 patients that had an oral exam and heart surgery. And when they went to the operating room, they took the plaque out of their coronary bypass arteries, scraped all the plaque out, and then looked to see if they had any bacteria. And they found that the total bacteria and the periodontal bacteria were found in 94 and 93% of the atheromatous plaques of patients who suffered from periodontal disease, but only 80 or 20% of the patients who were periodontally healthy. So the conclusion is the presence of microorganisms in coronary lesions is not coincidental, and in fact they may contribute to the development of vascular disease. So that's in the coronary arteries. These 5 bacteria are the ones that are most often found in the coronary vessel disease. But it's also present in carotid plaque bacteria. So in this small study, 13 patients 16 patients who had carotid bypass surgery had their plaque scraped out and tested for periodontal bacteria, and 81% had bacteria from their mouth living in the plaque in their carotid arteries. So which bacteria? 4 of the same bacteria, 4 of the 5 same ones. So we're seeing a trend here of these pathogenic periodontal bacteria are showing up within the plaque of the arteries. So not only in the coronary, but also in the carotid, and probably everywhere else. I mean, legs and wherever we might have plaque, we're going to find these bacteria. So we now believe, we believed this a long time ago, and then we sort of fell out of favor, but I think we're now back believing again that periodontal pathogens directly cause atherosclerosis. Oral flora trigger atherosclerotic vascular disease, and they do this by accelerating the atherosclerosis of the coronary arteries by 3 distinct and different mechanisms. So this is a paper published in November 2016 in the British Medical Journal. Principal authors were Brad Bale and Amy Deneen, and they discovered or outlined 3 distinct mechanisms. And this paper is really worth downloading and having in your library if you believe in cardiovascular prevention. So the first way is the elevation of serum lipoproteins. The next way is enhancing endothelial permeability. And the final way is advancing lipoprotein binding within the arterial intima. So how do they do that? Well, we got 5 bad actors, and it's the same dang bacteria that we're finding over and over that are found in plaque do these 3 different mechanisms. I use oral DNA's periopath test to do spit tests in my office because I'm a primary care provider, but I couldn't get my dentist to do it. So I just became a vendor and just started measuring these bacteria. And if I find these bacteria in somebody's mouth, I'm sending them to my local dentist to get that mouth cleaned up. And I heard a comment, somebody said, well, I'm only finding the same recommendations on that 3rd page of the test. So why would I do it if the recommendations aren't any different depending on which bacteria? Well, that's a laundry list of recommendations. It's your clinical acumen that tells us which of those to pick, or something else, or to use essential oils or oil pulling or whatever it is that you all have to offer. If you want us to prescribe antibiotics, we'll prescribe antibiotics. If you don't want to do that, if you think that's clinically indicated, but together we can make the patients better. So the first way that these bacteria work is by elevating serum lipoproteins. So if we believe that cholesterol and LDL cause heart disease, we're barking up the wrong tree. We got to go over to the other tree, which is the new paradigm. And the new paradigm is that it is apolipoproteins and oxidized LDL and inflammation that trigger atherosclerosis, not cholesterol and LDL. We need cholesterol and LDL. We need them to build our cell membranes. We need them to make my favorite vitamin D. We need them, for so many other things. Cholesterol is integral. And the people with the highest cholesterol live the longest, as long as it's not corrupted. It's kind of like teenagers, right? So I have 3 beautiful, amazing children. They're not all teenagers are 17, 20, and 21. But when they were teenagers, I wanted them to look like this. I did not want corrupted teenagers. And if they had corrupted teenager friends, I didn't want them in my house. Well, this is the same story with cholesterol. When you have healthy cholesterol, it's not a problem. When you have corrupted cholesterol, you got a problem. So how does that corrupt cholesterol get corrupted? Well, one way it can get corrupted is to get too small. So I tell my patients about their marshmallows. So I say, we want to have big, fluffy marshmallows. If I have a cup of cholesterol, I want you to have 1,000 lipoprotein particles in that cup. If you have 2,000 particles, your particles are too tiny. That means each one of these has an ApoB attached to it. ApoBs act like little submarines to carry those cholesterol particles behind the drywall and into the plaque. If you have big fluffy marshmallows, you're not going to have a lot of ApoBs. You're not going to have a cholesterol problem. But if you got corrupted cholesterol and itty bitty tiny ones, you're going to have a problem. So what do microbes do? This study is the Billiot study, and it was the first study that shows the direct relationship between secretory phospholipase A2 activity and the periodontal microbiota. These findings raise the probability that this enzyme activity could mediate the link between periodontal infection and atherosclerosis. It's a smoking gun, right? This is one of the direct ways where periodontal bacteria makes atherosclerosis. Another way that bacteria are bad is they enhance endothelial permeability by at least 4 different mechanisms. There's high risk, these 4 high risk gram-negative pathogens can generate lipopolysaccharide. We know what a problem that can be for the inflammatory cascade. Persistent exposure to inflammation leads to senescence of the endothelial cells. It causes them to detach and become more permeable. So just like you have a leaky gut, you have a leaky endothelial membrane. These high-risk pathogenic bacteria produce a toxin called leukotoxin type A, and this toxin generates endothelial apoptosis. It kills your arteries from the inside. And then there's a protein on the surface of these cells that causes a relocation of calhedrin away from the cell-cell junctions, causing the endothelium to be so permeable even a large molecule like a bacteria can pass through. The third mechanism that gram-negative bacteria use to advance atherosclerosis is by causing lipoprotein binding within the arterial intima. So microbial infection is known to stimulate genetic transcription of contractile smooth muscle cells to synthetic smooth muscle cells. So they go from being nice and bouncy smooth muscle cells to kind of scarred and thick smooth muscle cells. And they create a proteoglycan-enriched extracellular matrix within the intima. These proteoglycans have negatively charged ions, which means they can attract what? Heavy metals and apolipoprotein B. So we now have learned 3 different ways that gram-negative bacteria from the mouth cause atherosclerosis. I think that's a really profound place to be in today's milieu, and why I'm so honored to be in a room of dental practitioners, because we're directly connected now. So let's talk a little bit about vitamins. So many of you have heard me talk about vitamin D, right? We thought in the old days vitamin D regulated calcium, but now we know that not only does it do that, but it also regulates the immune system, and it regulates blood pressure and insulin production and the immune system and autoimmunity and apoptosis and cell growth and all kinds of other things. So vitamin D is my very favorite vitamin, but really, since I last lectured to ICIM about vitamin D, I've now learned that vitamin D is really only one leg of a 3-legged stool. And you need all 3 vitamins present together in order to get the benefits of any one of them. And they all help to enhance where calcium and magnesium are going to go. So vitamin K2, via its effect on calcium metabolism and the matrix GLA protein, and for those of you geeks who care, GLA stands for gamma carboxyglutamic acid, the matrix GLA protein, directly reduces dental plaque, directly reduces dental caries, and reverses coronary calcification. I just said reverses coronary calcification and enhances endothelial elasticity. So there's a bunch of vitamin Ks, just like there's a bunch of vitamin Ds. Vitamin K1, phyloquinone, is naturally found in plants. It's the one in green vegetables, and it's the one that helps with clotting. That's not really the one we're talking about that plays with vitamin D. Vitamin K2 is menaquinone, and there's several versions of this. It goes straight to your blood vessel walls, your bones, and other tissues besides your liver. And there's a vitamin K3, which is a synthetic form that I don't recommend, just like I don't recommend synthetic vitamin D. So that's kind of what they look like. They're long chain carbon hydrogen chains. And vitamin K2, MK7, has 2 primary isotypes. One is called MK4 and one is called MK7. And if you pick up a bottle of vitamin K2 supplementation, you'll usually find it labeled to be one of these 2. MK4 is a short chain form. It's found in butter, egg yolks, and animal-based foods. Most of the supplements are synthetic. They're not naturally food-derived in most cases. But important to know is MK4 has a very, very short half-life. So if you're going to use it for your patients to help do all the good things that vitamin K2 does, and it works, it must be BID to TID dosed. On the other hand, MK7 is the longer form chain. It's found mostly in fermented foods or in supplements. And these long chain forms have a long half-life, and it only needs to be dosed once a day. So since I only dose my vitamin D once a day, I generally choose the MK7 form, so I only have to dose my vitamin K once a day. So naturally occurring sources of vitamin K2 are grass-fed animal products, but only when there's a lot of spring grass present. So you have to have the cows eating the rich spring grass in order to make the milk that makes the butter that's high in vitamin K2. Same for the chickens and their eggs. A lot of fermented foods are high. The highest source on the planet is natto, which I'm not a big fan of. I don't know if any of you ever had this fermented soy product. It kind of smells like dirty socks and it's kind of slimy, and it's made from fermented soybeans. Not my favorite, but the Japanese use it a lot in their cooking cuisine. Most fermented vegetables are not that high in vitamin K2. They come in at about 50 micrograms a serving, but starter cultures you can have more. It's high in goose liver pate, and it's high in soft cheeses such as brie and Gouda at about 75 microgram per ounce. And note that in the cheeses, it's the bacterial fermentation that causes the high K2, not the milk. And these are vitamin K producing bacteria from foods. These are the top 4 bacteria that are known to produce vitamin K2. So this GLA protein is a unique amino acid that's created by vitamin K dependent post-translational modification. And when it does this transformation, it changes a promyoblastic cell into an osteoblast. So it's going to actually grow new bone. I think that's critically important for us as we treat these osteoporosis patients. We get those heavy metals out of their bones and they have to build new bone. We have to give them what they need to make those new bone cells. Without vitamin K2, you can't activate their protein. And calcium can harden in the arteries the same way that calcium hardens in the bones. So we want to have vitamin K2 present so that it hardens in the right place. MK4 regulates gene expression of these vascular smooth muscle cells. And in the absence of vitamin K2, we get these osteoblast-like cells growing in the arteries, causing arterial calcification. So MK4 causes anti-calcification component in the artery wall. So the Rotterdam study showed us that of 4,800 patients, those with the highest levels of vitamin K2 had a 57% lower risk of dying from incidental coronary artery disease, which I thought was really interesting because that's almost the same percentage as the reduction in diabetic mortality in the TAC trial. So I think it's interesting, and I won't be surprised if we find some greater connection as we study this deeper and deeper, how our chelation can help the patients live longer and better lives. 26% reduction in all-cause mortality and 52% reduction of atherosclerosis. So there's the graphs that demonstrate that. How am I doing on time? Can somebody, oh wait, I've got to watch. So I was supposed to be done at 2:30, is that correct? Okay. High dietary vitamin K2 reduces coronary artery calcium. Metaquinone, but not the vitamin K1, the blood clotting one, is associated with reduced coronary calcification. So intakes could very well be an important mechanism for us to prevent cardiovascular disease. So when I say plaque, the dentists in the office think of one thing, and the doctors in the office in the space think of something else. So probably they're connected, right? And I think they're probably more connected than you think. And if you're interested in learning more about vitamin K2, one of the regional experts is from Toronto, Canada, Kate Roumet-Bleu. And she has a book, Vitamin K2 and the Calcium Paradox. It's an easy, quick read, and it really pulls in a lot of the science. I think it's a good resource for you to have. She has a lovely blog as well. So what is a good ratio then? If I'm going to supplement with 5,000 international units of vitamin D, which is probably the mean of what most of my patients take, how much A and how much K2 should I give? Well, there is not really an established role for the ratio of these fat-soluble nutrients. And in fact, if we look at the RDA in the United States, or what vitamin D is supposed to be given at, even after they met with all the best experts, they still came up with some measly 1,200 international units, which we know really doesn't get anybody into what we would call a therapeutic range of vitamin D. But the rule that Dr. Kate goes by is equal amounts of A and D with 100 micrograms for every 1,000 units. So if you notice, it's going to be like 5,000 of A, 5,000 of D, and 500 of K. And that will give you a reversal of atherosclerosis. We don't know yet if increasing the dose of D necessitates an ever increasing dose of K2. If there's some demand supply benefit place where it maxes out, we don't know. But we do know that since vitamin A has a MK2, vitamin K2 sparing effect, it's probably okay to stick at 500 even if you go way higher on the others. Now, also recognize that there's a lot we don't know about these vitamins, right? We know that if we give plain vitamin A without its whole mixed spectrum that we would get by eating a rainbow color of foods, we're going to be limited in, we may increase the risk of lung cancer, especially in smokers. But as you pick apart those studies, you really need to see, well, what did they give them? They gave them a vitamin A capsule of retinol, right? Only one vitamin A. Well, it's really found in nature in a spectrum. And so as we go downstairs or we choose our nutritional companies, we want to ask them to provide us with mixed carotenoids in that. We want some beta carotene, we want some alpha, beta, gamma, we want all the different vitamins A's in there, not just one kind, because that's how we're going to find it in nature. So I think it's behooves us to encourage our patients to eat the rainbow of colors, but also to supplement, especially if they have known atherosclerosis. So we have these acupuncture meridian electrical grids, right? And many of you, this is how we do acupuncture, and we have these, the flow of energy that goes through our body. Well, Simon Yu developed this tooth organ meridian chart. I hope this is not new to any of you, but if it is, please make a copy of it and keep it in your exam room. I use it almost every day in my clinical practice. And basically what this shows us is for where the reflex points are from these energy places of one part of your body to your mouth. So, for example, I had a patient with, with your bladder problem. I could not get her urinary tract infections to go away. So she was 55 years old, and she had UTI after UTI after UTI. And I could not figure out why. Well, then I found Simon's chart, and I looked that these front teeth are directly connected to the urogenital area and the bladder. And I asked her, Catherine, do you have any problems with your teeth? And she pulled her lip down, and shame on me for not looking first, right? But she pulled her lip down and showed me the tooth roots of her two front teeth. She said, my dentist and I have been working on these for the last 8 months. First I had a cavity, then I had a filling, then I had a root canal. Now he's thinking I have to have those pulled out and I might have to have implants. We can't seem to make these teeth better. I said, well, holy cow, I am never going to be able to heal your urinary tract infections, likely, until we get this mouth thing taken care of. And then she's not my patient anymore, so I don't know how that story ends. But it was just remarkable to me to make that connection and to show the patient the paper and to have the patient make the connection as well. But because this talk is about cardiovascular, we're going to look here and we're going to see that these wisdom teeth are energetically connected to the heart. So, that was interesting to me. So I have this patient. She's 49 years old, I think. And she doesn't really have a whole lot of cardiovascular risk factors. Her apolipoprotein levels are like 84. She has all of her that's her biometrics. So she's not obese. Her blood pressure is 100 over 73. Her body mass index is like 22. Her oxygen level's 100. Everything's good. Those are her NMR lipoprotein. Everything is green. She does not have cardiovascular risks. And yet, when I did her labs, she has this huge elevation in lipoprotein A levels. I'm like, well, I don't know what that's about. Go see your dentist. So she went to go see her dentist, and she got cleaned up, and her lipoprotein level came back even higher. It's now 230 something. And I was like, Lauren, I need you to go back to your dentist. Please have him check your wisdom teeth. She's like, my wisdom teeth were pulled out like 35 or 40 years ago. I don't have any wisdom teeth. I said, well, it's just a hunch. I can't prove it. I don't know what you got, but I go back to your dentist. So she went back to her dentist, who took an x-ray and said, there's a little bit of a dark shadow maybe there, but it's been there for years. It's not changing. It's not growing. I said, pick a different dentist. So she went to go see a different dentist who, Yes, slight shadow, no change. The second data says, I have a high suspicion of necrotic bone at that tooth socket where that wisdom tooth was extracted more than 3 decades prior. So as you can see, she's had a lot of dental work. And this is not a tooth. I thought this was a tooth, but this is a cone beam CAT scan of her jawbone. So you're looking at it like a slice of bread, looking at it end on. And this is what the normal bone should look like. All of this dark stuff here is dead and necrotic bone. So she ended up seeing the surgeon, and having a cavitation removed from that wisdom tooth that was there 30 years later. Her LPPLA2 number has dropped to about 150. Normal is 125. So we're not normal yet, but we're trending down for the first time in 2 years. So I'm very hopeful for her. Her dentist and I had a conversation. I think we're going to do some more ozone in that area based on some things I've heard at this conference. There may be a couple other things that we do to help make her feel better, but we were able to significantly improve her long-term cardiovascular history, even in the absence of cardiovascular disease, because we now know from all of that dental work that I just showed you, and women present cardiovascularly differently than men. I can't tell you how many women I've had who've been on the treadmill, passed their treadmill stress test, and they were sent home fine and then went on to have an MI. Women often will have these MIs from different vascular disease. We get coronary spasm, and I believe that gluten can be a trigger to coronary spasm in sensitive patients. We see women get small vessel disease and erosion. They don't have the big typical plaque, thick atheroma with a plaque rupture that men do. We also get smaller vessel disease. So I think that knowing what I now know about the role of gram-negative bacteria that she had living in her jawbone, that we're able to reduce her future risk of a heart attack or stroke, even though she didn't have many risk factors, because that's what we want to do, is reduce our chance of stroke and heart attack to reduce it to near zero with our proactive prevention. And working together, the dentists and the clinicians in this room, we have a fabulous way that we can make a better outcome for the patients that we care for. So that's everything that I have, and I'm finished a few minutes early despite my technical difficulty. You have questions? You want me to go back and show you all the cool graphics that you missed at the beginning? Yeah, Mike. I don't know, did you? Yeah. He did, and they looked okay. Yes, sir. So do I recommend any particular brand of K2? There's not, so far, really no. The one that I've been using is Nutritional Frontiers, just because it's a new vendor to us, but they have a single pill that's got vitamin A 5,000 retinol, which I don't like, but I'm having to tell the patients, take this and eat a lot of salad. Vitamin D 5,000 and vitamin K2 as MK7 as 500 mics. And it's like $60 for 60 pills. So it's one of the most cost-effective ones. There's lots of vitamin K drops out there and other companies. I think Energetics has a K2 drop. And I've used a lot of them, but I like this particular one because it's just 3-in-1 for a very cost-effective price. I'm actually thinking I want to talk with some of these vendors and see if they can create a really good one that has several versions, like maybe mixed carotenoids of A at 4,000, 4,400, 2,000, 2,200, 5,000, 5,500, because I'm thinking we probably don't need 500 all the time, just in the patients who have advanced atherosclerosis or that are new patients to yours that you're just working on getting them fixed up, or you've just chelated them and you're trying to build new bone. I don't think we necessarily need to have that much K2 all the time. So just an educated guess. Yeah, Joe. So how do I look for these oral bacteria? Well, there's Oral DNA is the name of the company. The test that I use is called Periopath. And so you simply take their little kit, open it up. You put about a teaspoon, 5 mLs of a saline solution in the patient's mouth, have them swish for, I think, 20 seconds, and spit back into the cone-shaped collection device, screw it down, and call for a pickup. And it gets sent off to the lab, and in a week or so, you get your results. And they will show you the 10 most common bacteria, including those 5 and 5 others. And they rank them into the very high risk for periodontal attachment loss, the medium risk, or the low risk. And then and then they'll track them over time, and you can see the graphs over time, because you want 0 of all of those if you can get there. And so far we're seeing improvement in the patients that we take care of, and I'm measuring carotid intima media thicknesses in my office, and I'm seeing those shrink, as we're doing all this stuff, because that's an easier way than many and less invasive to see if what you're doing is actually working. So when you have a patient who's got who's 45, who's got the arteries of a 99-year-old, and then they come back in 6 or 8 months later and they got the arteries of a 75-year-old, you're making some really serious progress in a relatively short time. Yes. Yeah, so what do I do to reintroduce normal flora? So I think about the same for our gut recovery program that we do for GI bacteria is similar to me in the oral flora. So we say remove, replace, reinoculate, and repair. So you got to remove the bad stuff. So that's where the dentist can help us, right? You want to get rid of the plaque if it's on the teeth. You want to make sure they keep up with their cleanings. You want to make sure that they're using something to disrupt those plaques as they go. I happen to be a fan of flossing. I recognize that it's controversial to some people. I have space between my teeth that I need to get that stuff out, so we floss. But I also like those little brushes. They look like little pipe cleaners, and you can use those to help disrupt that plaque before it forms. So remove. Then we replace. I use a probiotic. Zymogen has a Probio DDS. That's a streptococcal strain that's a healthy, friendly probiotic. Seems to keep some of these other guys down. You chew it at night after you've used your nightly oral care. Replace, remove, replace, reinoculate, repair. So we want to repair, make sure the patient has all the good things. And we had a lecture on that earlier. Make sure they're taking their bone broth, their multivitamins, their glutamine, their aloe, all those things that we do that help enhance the mucus, because you want good saliva, healthy, not too thick and sticky saliva. Oh, by the way, almost everybody that starts taking MK7 as a nutritional supplement tells you that their teeth are slipperier, that they don't get so sticky, that their saliva is less viscous and thick, and that it seems like their oral care is easier to keep up with. They don't have as much junk on their teeth. So I've only been using it in my practice about maybe 9 or 10 months, so I don't have long-term experience with it, but just in the short term, I am seeing that change. Another test that oral DNA does is, for some people, they may have low or moderate amounts of these ugly 5 bacteria, these ugly actors, but yet they're genetically predisposed to have a very robust inflammatory response to those oral bacteria. And so there's a secondary level of test. If you do the bacteria count and it's not all that many bacteria, and you go, well, that's kind of weird because the patient's got raging periodontal disease, but their bacteria counts aren't that high. You can do that secondary test to look to see if they're genetically robust inflammatory people, and then those low levels are much more meaningful and you're much more aggressive in taking care of them. Yes, in the way, Mike, in the way back, you have another question? EC1734E. It is heat sensitive. We send it with a freezer brick. Question. Yeah. Yeah, the kit tells you the things you're not supposed to do. You're not supposed to smoke. You're not supposed to brush your teeth within a certain. You're not even supposed to drink water a certain number of minutes before your test. Yeah. Oh, sure. Yeah. So it's not the be all and end all, but I'm a primary care doctor. I'm not a dentist. So having something to make that connection for my patients to underscore objectively the importance of getting to their dentist is a great tool for me as a primary care doc. In fact, I would be willing to say I think it's probably a better tool for the primary care doc than it is for the dentist, right? If you all have phase contrast and you have all those other tools in your office and you got that machine and you can tell me in 30 minutes if I got bacteria, right? That's cool stuff, for it, but that's not what we would do in our office. Yes, sir. Yeah. Right. Right. And that biomeridian chart is another really valuable tool to convince the patient that their symptom that they're complaining of is relative to their mouth and that they need to go to the dentist and get that taken care of. Also, the biomeridian is the thyroid and the breast are on the same meridian, and I almost always see thyroid, breast, and jaw connected whenever there's a breast cancer patient. So I think that's our time. Yes?